Northeastern University.
Okay, I think Genevieve started out with the 10, 9, 8. Genevieve, lead us again with the exercise. We've got 2 more to go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. 2 speakers left. So I'm going to pick up where Jim Hester left off. He said that how are we going to pay for population health? And my focus is going to be on looking at the examples of the 2 ways that I believe you can pay for population health on a widespread scale. One is the one at the bottom, and that's the traditional way. You pay for it with public health funding, with grants. We've heard about foundation grants and government grants. This gives some examples of what those are. The top bullet is the new and innovative approach, and that's whether or not we can create incentives so that we can get insurance to pay for population health or incentivize clinicians to use some of their resources to do population health, and again, population health meaning health of the larger community. I'm going to give you 2 examples of each of those from the Massachusetts experience, and I won't go through them now because I'll tell you when I go through them, and I'm going to skip over a few slides and just get right into those. So the first option, again, is the traditional one. That's the fund public health to do population health. I believe we should continue to do that, and I'm going to offer 2 innovative approaches of ways to fund public health that build upon the traditional approaches. The first was in Massachusetts. We developed a program called Mass in Motion when we had no money at all to deal with obesity, starting in 2009. And so our approach was to essentially say the role of public health is to be the convener, to identify this as a serious health issue, to bring lots of people to the table, and to identify a plan that everyone could work together to put into place. But we had no money. What we were able to do, though, through a very inclusive process, was then draw on some of the participants in the process. In this case, it was 5 foundations and an insurer, all Massachusetts-based foundations, to contribute some funds to get this effort going. And from that effort, which was the idea had many different components, but one of it was to give grants to local communities to change policies. We evaluated that preliminarily. It looked positive. We later were able to get a hospital system to contribute $1 million, and we were very fortunate then to have enough evidence that it worked so we could apply for the community transformation grants. So we now have in Massachusetts about a $9 million program that's focused on policy change at the local level, coordinated by the state, but overwhelmingly not funded with state dollars, and genuinely a public and private partnership with the 5 foundations and the insurer and the hospital system complementing the work, the funding from the Centers for Disease Control. I won't go into what those are doing other than to say that those grants now reach about 50 cities and towns in the state and reach about 1/3 of the population. And in each of those communities, there have been innovative efforts, not unlike the ones that you've heard of in California, where there were really grassroots levels to mobilize people and give them the tools to begin to change policies and conditions in their communities. The second way that I'd like to offer as an innovative approach to the traditional approach of public health had to do with the creation of a prevention and wellness trust in Massachusetts. Massachusetts is known for having passed a healthcare reform initiative in 2006 that led to our having the lowest percentage of the population that's uninsured now. But in fact, there were 4 different bills that were related to healthcare reform that were passed, each one at 2-year intervals. The most recent one was passed in 2012, and that one focused largely on cost, quality, and prevention. And in that bill, the latest of our health care reform bill, we created a $60 million prevention and wellness trust that would, over a 4-year period, fund these kinds of activities. 75% of the funds need to go to reducing preventable health conditions, disparities, promoting health healthy behaviors and adopting workplace wellness programs. The funds for that legislatively mandated trust came from a one-time assessment on the insurers or health plans within the state and the hospitals whose bottom lines were above a certain amount. And they, by the way, the health plans and the hospitals were at the table as this was discussed, and they liked the approach of the trust. They didn't necessarily like where the money was coming from, but they felt like it was needed, and that the fact that it was recognized as necessary really came from many years of working to develop the kind of cultural atmosphere that Dean Shortell was referencing before, so that we could float an idea like this and have it be considered and ultimately passed. So the second type of option is the one I think that is increasingly getting attention in the era of global payments and the Affordable Care Act, and that's whether we can tap insurance or clinical funding to pay for population health. So here are two examples of that on the Massachusetts. The first involved a legislatively mandated committee that was called the Statewide Quality Advisory Committee, or SQAC. It was created by the legislature to identify performance metrics and uniform reporting that could help to guide the State Division of Insurance in setting standards that all insurers had to follow. And it was thought that it might also provide some uniform guidance so at the point that licenses were being issued to accountable care organizations, there was a agreed-upon set of metrics. The committee was led by the head of two different departments. I was one of the people who was chairing it. And an important part of the process that I'd highlight for you was that while it started out by ensuring it was going to look at the standard clinical measures, the HEDIS measures and such, it also made it a priority that it was going to examine whether there were health measures that looked at population health that could be included in the standard metrics that would be considered as a statewide model. And here you just see the language to focus on that. You see the picture of Paul Jarvis from ASTHO, because part of the SQAC's work was to hold specialized days where experts were brought in to give us the state-of-the-art on metrics in different arenas, and to help us think through creatively, were there new approaches? We had a day where we focused on population health and the attempt to identify metrics that could be used, and we brought Paul in, and he was very helpful in terms of our thinking that through. What was the conclusion? Well, we were operating on a tight timeline for the first year's objectives for the committee. And so we ended up deciding that we couldn't select the appropriate population measures. Part of that was true, as Jim said, part of that was because there were so many other clinical measures that already were being collected that just going over those took so much time and energy that it kind of crowded out the focus on population health. The second was, people don't want additional measures. If you're a clinical practice, if you're a hospital, you're doing a lot of measures already, and so getting an additional measure added is not so easy to do. So there was a general resistance to the notion of a new category of population health. And then finally, as you heard earlier, it just was a bad fit. When we were looking at the kind of quality measures that basically capture what takes place in a 15-minute clinical visit, you can't really put a population health measure there. Partly what we concluded, while we couldn't come up with the measures in that setting, was that there was an opportunity to think about population health measures in a different setting, and that was in the at the regulatory level, perhaps for the Division of Insurance, or at the ACO licensure level, or in the hospital regulations, where you could talk about system quality measures that were population-based, not clinical quality measures that looked at a single encounter. And so I think that while we didn't come up with concrete recommendations, we refocused our attention to begin to think about whether there were other arenas where those population measures might still fit. And then finally, the innovative approach that I would share with you had to do with our attempt to consider whether we could reduce costs, improve health, think about population health by standardizing the use of community health workers as part of clinical teams with an outward focus that attended to population-based conditions. What we realized was virtually all of our community health worker programs in the state were grant funded. We're fortunate enough that we now have a waiver to do a very limited pilot around asthma through Medicaid, but overwhelmingly, I'd say across the country, community health worker programs are funded by grants. So the idea with creating a statewide board of certification, and this was done again with legislative support, was to consider if one of the ways of transitioning to the routine use of community health workers was to have the state certify community health workers or promotoras in a way that would give confidence to clinical providers, hospitals, and health centers. So that as they looked at the increased use of global payment systems, and we encouraged them to think about community health workers as members of the teams, they had a way of considering whether those individuals actually had adequate training and the approval of the state for them to be hired and included on a routine basis. The Board of Certification is housed within the Department of Public Health in the same location where Board of Nursing is housed and other health professionals. The board itself its members are appointed by the governor. It's now going through its first year, and its first year it's looking at such issues as what the training requirements should be, what the certification standards should be, how often people should need to be recertified, and we should know more about that by the end of the year. So just in summary, what I would suggest is that these are 4 different areas that are worth paying attention to over the next year. We're going to be using some of the innovation funds from CMS to evaluate the Mass in Motion program and also to link it more to the provision of primary care. So over the next year, we'll see a growth in terms of Mass in Motion moving first based in population health and now moving towards clinical care rather than clinical care moving towards population health. These were grant-funded programs that now are going to try to link to the clinical providers. Secondly, the Prevention and Wellness Trust, the governor has appointed members to the advisory committee for that, and the first distribution of funding should occur within the next 6 months to 9 months. And so we'll see, does that type of an approach work to promote population health? And then again, we'll know in the second year of this, the SQUAC's activities, how it chooses to address the issue of population health and whether or not it considers those approaches I was mentioning earlier. And then finally, with the Community Health Worker Certification Board, we expect within the next 6 months it will complete its regulations, and then we'll begin to see whether or not we see wider usage and incorporation of community health workers into the healthcare system, being paid for the first time by global payment systems rather than by grants. So with each of these, I'd say stay tuned, and we'll try to assess the progress that's made and report that back so that people can learn from the experience. Thanks.
Thank you, John. Last but not least is Julie Trocchio, who serves as Senior Director of Community Benefit and Continuing Care at the Catholic Health Association. Julie.